So we talked quite a bit about calcium regulation in the pathology section, and I'm not going to belabor that point here. But before I talk about the specific causes of hypo and hyperparathyroidism, I want to walk you through this beautiful graph I've adapted from First Aid and tell you exactly why I like it so much. This is a graph of parathyroid hormone versus serum calcium, and the normal physiologic range for both exists around here. Not drawn to scale, of course. Now, the reason I like this graph so much is that with all the positive stimulation and negative feedback stuff in endocrinology, it gets kind of tricky to know what to expect, and this graph provides a perfect visual way to break it down. For example, if your calcium is too high, do you think the parathyroid hormone is going to be running high or low? Now, you might say increase because parathyroid hormone does cause calcium to increase, but it's kind of like a chicken or the egg question, isn't it? I mean, sure, if parathyroid hormone becomes increased because of, I don't know, like a parathyroid adenoma or something, it's going to cause the calcium to go up with it, because that's just what parathyroid hormone does. But what will happen to the parathyroid hormone if the calcium goes up on its own? Remember, PTH's job is to increase calcium if calcium isn't high enough. But if calcium goes through the roof on its own, PTH goes, well, I guess you guys have it covered, and leaves for the Bahamas. You can also work this out vice versa. If PTH decreases because some ENT managed to take the paras out with the thyroids, the calcium is going to drop. But if calcium drops on its own, then parathyroid hormone, in an attempt to correct for that low calcium, is going to skyrocket. Now, look, I know this is getting a little bit messy, and you're probably getting tired of me geeking out over graphs, so I'm going to make this very simple for you. PTH increases calcium. So, if the two are directly proportional, meaning either that both are increased or both are decreased, then it's pretty safe to say that the problem is with the parathyroid gland itself. Conversely, if the two are inversely proportional, meaning PTH goes up while calcium goes down, or vice versa, then the problem is a PTH-independent calcium abnormality. Now, you're probably still asking yourself, okay, why do I have to know this? Because you're going to be presented with this kind of information all the time on the test when it comes to calcium metabolism. You'll be given some clinical vignette that looks like this, and then you'll be asked what the PTH value and the calcium value look like. Or you'll be given a set of labs that looks like this, in which case you need to be able to identify what kind of pathology you're dealing with. In this case, with a low calcium and a low parathyroid hormone, what are we dealing with? They're both decreased, which tells you that it's probably a problem with the parathyroid. And since PTH is decreased, the problem is hypoparathyroidism. And now that we've thoroughly beaten problem solving with calcium metabolism into the ground, let's get started with some disorders involving low PTH. Now, true hypoparathyroidism, as I mentioned, occurs when low PTH causes the calcium to run low. So how can a person become hypoparathyroid? We went over this one just a minute ago. So the parathyroids can be accidentally removed during a thyroidectomy, for one. They can also be destroyed via autoimmune disease, kind of like Hashimoto's thyroiditis. Finally, what's one genetic syndrome that causes parathyroid dysgenesis? Has to do with the branchial arches. The answer is DeGeorge syndrome, the one that involves dysgenesis of the third and fourth branchial arches. Review question for you. Which other organ comes from those branchial arches? It's the thymus, and DeGeorge patients are also known for having thymic aplasia. Symptoms of hypoparathyroidism are pretty much symptoms of hypocalcemia, which will be gone over in a lot more detail in the renal section, but a couple of the ones I want to go over right now are the Chvostek and the Trousseau sign. Chvostek on the cheek, and Trousseau on the triceps. Both are basically signs of nerve hyperactivity when you irritate it. With the Chvostek sign, if you tap on the cheek, the hyperirritable facial nerve causes your face to twitch. And with the Trousseau sign, if you wrap a blood pressure cuff around the arm, cutting off circulation to the forearm, then the hyperexcitable forearm nerves will cause a carpal spasm. On the other hand, you can get a suppression of PTH if the calcium gets way too high on its own. Keep in mind, this isn't called hypoparathyroidism, since the parathyroid's actually acting appropriately to the stimulus of high calcium. Now, can you guess what the most common cause of PTH-independent hypercalcemia is? Weirdly enough, it's not anything obvious like eating too much calcium. The answer is actually cancer. Solid tumors can cause an increase in blood calcium by either secreting parathyroid hormone-related peptide, causing local bone resorption like in multiple myeloma or bone mets, or increased activation of vitamin D. Now, speaking of vitamin D, I hope you didn't forget that vitamin D is also an important PTH-independent regulator of calcium. Hypervitaminosis D is not only found in people who eat too many of those vitamin D capsules, but also in people with granulomatous diseases like sarcoidosis. I know I joked around with you earlier about people eating too much calcium. That's actually pretty uncommon, unless you also have chronic kidney disease and can't pee out the extra calcium. Now, I know this calcium metabolism stuff's a little bit tricky, so let's try a flash quiz just to see if you're still with me. The question is, what calcium and phosphate abnormalities might you see in a patient whose parathyroid glands were removed accidentally during thyroid surgery? Pause the video for a moment if you need some time to think about it. So, hypoparathyroidism, for example, from a surgical accident, falls to the bottom left portion of the graph I just showed you. You see a decreased serum calcium and decreased parathyroid hormone. Now, since parathyroid hormone increases your calcium and wastes phosphate, you would assume then that hypoparathyroidism will decrease your calcium and increase your phosphate. Now, I'm going to take a short deviation from this graph to talk about familial hypocalciuric hypercalcemia, which is a kind of a weird but fortunately low-yield disorder. Basically, it's an autosomal dominant disorder in which the high calcium can't inhibit the parathyroid like it normally does. So you get higher calcium than normal. So how's this different from your average garden variety hyperparathyroidism? Well, it's not like the parathyroid's completely run amok and is hypersecreting without regulation at all. What else regulates the parathyroid besides calcium? The answer is phosphate, and to a lesser extent, magnesium. So, when there's way too much PTH, the drop in phosphate will still inhibit the parathyroids as per usual, even though calcium's still not doing anything. As a result, the hypercalcemia is usually going to be pretty mild, and while the PTH can be a little bit elevated, it usually hovers around the high normal. So, I mentioned that the changes in labs are super important for calcium metabolism questions, and it's sometimes easy to confuse these labs with the labs in hyperparathyroidism if PTH is just above the border of normal. So, which lab value distinguishes familial hypocalciuric hypercalcemia and hyperparathyroidism? The answer is urine calcium. Even though PTH controls calcium excretion to a certain extent, if the calcium value is significantly elevated, the kidneys go, screw this, and start dumping calcium in the urine anyway. But with familial hypocalciuric hypercalcemia, you only have a mild alteration in serum calcium, so the high normal PTH can effectively decrease the calcium excretion. The important takeaway from this is that familial hypocalciuric hypercalcemia is a mild disease that's unique in the fact that it's got low urine calcium combined with an elevated serum calcium. But that in most other cases, the urine calcium will tend to mirror the serum calcium rather than the PTH. So, probably the hardest thing about this disease is this incredibly long wordy name and not mixing up the hypo and the hyper and what have you. Just remember that it's pretty much like hyperparathyroidism, light. If you understand the physiology of how PTH works, you'll remember that it has to be hypocalciuria and hypercalcemia. Back to our fun little graph here. Well, we'll start off with real hyperparathyroidism, not that wimpy familial stuff. Now, just to recap, what PTH and calcium abnormalities would you expect to see in hyperparathyroidism? Hyperparathyroidism is an increase in PTH that causes an increase in blood calcium and a drop in phosphate. It's usually caused by a parathyroid adenoma or hyperplasia. So, if you had to guess, what's the most common presentation of hyperparathyroidism? Now, chances are you said one of the various symptoms of hypercalcemia that rhymes with owns, but in fact, the most common presentation of hyperparathyroidism is, drumroll please, no symptoms at all. Actually, hyperparathyroidism is usually picked up as an incidental finding on labs because honestly, parathyroid adenomas don't usually bump the calcium up to critical or even symptomatic levels. It takes a surprising amount of calcium to cause symptoms, and in fact, a calcium over 13 mg per deciliter is more characteristic of a malignancy than a parathyroid problem. But occasionally, especially in the MEN syndromes I keep talking about, the adenoma is significant enough to cause symptoms of hypercalcemia. This is the famous acronym stones, bones, groans, and psychiatric overtones. So, stones are for the kidney stones that happen from the increased calcium in the urine. But wait, Arjun, says you, doesn't parathyroid hormone also decrease the amount of excreted calcium? Well, sure it does, but remember, urine calcium tends to follow the serum calcium when there's significantly elevated or decreased calcium. Let me explain. See, PTH decreases the urine calcium by increasing the rate of calcium transport in the nephron. But if calcium gets high enough, more calcium is filtered through the glomerulus, and eventually the rate of transportation is inadequate to clear the calcium. And of course, PTH is doing all it can to excrete as much phosphate as possible, hence stones in the urine that form when calcium and phosphate decide they want to be best friends in your urine. Bones are for the bone pain and fragility that come from the fact that PTH strips calcium and phosphate from the bone. This characteristic pattern that you learn about in the musculoskeletal section called osteitis fibrosa cystica, a condition where the elevated PTH causes characteristic cystic removal of bone. Now if you crack that bad boy open, the lesions would actually look brown because of all the hemorrhaging that goes on inside them. Groans stand for all the groaning you do as you're going to try to poop, because hypercalcemia causes some pretty gnarly constipation. Now try to get that image out of your head. And finally, psychiatric overtones stand for the psych conditions, usually depression, that often accompany hypercalcemia. Finally, let's wrap up with the PTH-independent causes of hypocalcemia that lead to increased PTH. This is probably the highest yield concept in calcium regulation physiology because the most common cause of PTH-independent hypocalcemia is chronic kidney disease. Now, there's no way I'm going to cover this whole mega high yield topic in the endocrine section. You got to read through the renal section for most of this, but I will briefly talk about how it pertains to calcium homeostasis. So, under normal conditions, the kidney is a net calcium absorber and a net phosphate secretor. When you lose functional kidney mass, you lose some of the ability to filter phosphate, leading to decreased urinary phosphate and increased phosphate retention. You also lose your effective vitamin D, and how's that going to affect your calcium and phosphate? Well, the decrease in vitamin D is going to decrease the gut absorption of calcium, lowering the serum calcium levels, and while you're going to have decreased absorption of phosphate as well, it doesn't really make up for the lack of phosphate secretion from the kidney. So, the poor parathyroid sees this drop in calcium and the increase in phosphate. What would be the appropriate response? So, the parathyroid gland is going to start hypersecreting PTH in order to try to normalize the levels as much as possible. And it works for a little bit. But the problem is, it's an uphill battle because chronic kidney disease is progressive. The phosphate secretion is going to get worse and worse, the phosphate retention is going to get worse and worse, and the vitamin D secretion drops lower and lower, which continues to drop the calcium. So PTH has to keep working harder and harder to keep normalizing these values, but it can't completely compensate once kidney disease gets bad enough. By the way, where's PTH getting all this calcium from that it's trying to use to compensate? Well, the problem is, since vitamin D is not providing adequate gut absorption, the main source of calcium is the bone. So you're going to get these bone lesions with chronic kidney disease as well as with hyperparathyroidism. But because of the etiology, it's called renal osteodystrophy. So this disorder is called secondary hyperparathyroidism, a name that I think is a little bit unfair because the poor parathyroid gland is actually exhibiting a totally appropriate response to deranged electrolyte values. But unfortunately, the parathyroid can go totally wacko from the continuous hyperplasia over the course of chronic kidney disease, causing ridiculously out of control PTH secretion that's known as tertiary hyperthyroidism. You call this tertiary once it gets bad enough to cause actual hypercalcemia. One point about bone disease caused by elevated PTH, no matter what the cause, the increased bone turnover causes elevations in alkaline phosphatase. Does that sound familiar? It's the same enzyme that's assessed in the liver panel. You know, AST, ALT, GGT, alkphos. Turns out the enzyme's not only present in the biliary tree, but also in osteoblasts for synthesizing hydroxyapatite. Finally, pseudohypoparathyroidism is part of a syndrome called Albright's hereditary osteodystrophy, Now this one's a bit confusing because it's called pseudo-hypoparathyroidism, even though the mechanism's pretty similar to secondary hyperparathyroidism. In both cases, the kidneys are the real problem. In Albright's hereditary osteodystrophy, however, the kidneys are working, but they're insensitive to PTH, so they waste calcium and don't adequately secrete phosphate. And just like with chronic kidney disease, the PTH is actually high. Because remember, the problem's not with the gland, it's reacting to a problem somewhere else in the body. Unlike secondary hyperparathyroidism, there aren't any lytic bone lesions because the disease strikes early in life. There is, however, stunted bone growth and a characteristically shortened fourth and fifth phalanges. It's kind of like the difference between osteomalacia and rickets. Adult disease causes bone brittleness, whereas childhood disease causes bone deformity. Remembering the names can be extremely confusing, but if you're a visual learner, try to remember its position on the graph, and remember that both secondary hyperparathyroidism and pseudo-hypoparathyroidism are actually problems with the kidney.
To make matters even more confusing, there's a disease called pseudo-hypoparathyroidism, which actually has nothing to do with calcium regulation. It's basically the phenotypic appearance of someone with Albright's hereditary osteodystrophy, but with no insensitivity to PTH. Nothing super high yield, but just remember if you see this name, it has nothing to do with alterations in PTH or calcium. They're just funny looking.
So rather than doing a flash quiz for this section, I want to make sure you guys are all comfortable with doing the lab value type questions that you're going to see all the time for calcium metabolism. Now, this isn't really the kind of thing you can flash fact your way through. These are problems that you really have to work through yourself to be comfortable with. So take these seriously and pause the video if you have to think about them, because this is a lot like how the questions on step 1 are going to be. First, if a patient's got a parathyroid adenoma, what are their lab values going to look like? So the root of the problem is increased PTH, which causes the calcium to go up and the phosphate to go down. So this is a primary problem with the parathyroid gland, meaning that the PTH and the calcium are going to be directly proportional. For the you visual learners out there, this is going to be in the top right portion of the graph. What about DeGeorge syndrome? The problem here is aplasia of the parathyroid glands, meaning you're going to have a drop in parathyroid hormone. Because this is, again, a primary problem with the parathyroid gland, PTH and serum calcium are going to be directly proportional, and you're going to see decreased serum calcium and increased serum phosphate. Finally, how about this weird one? Pseudo-hypoparathyroidism. Stop and think about this one for a second. Where's the problem really at? Remember, it's a lot like chronic kidney disease. The problem is that the kidneys are unresponsive to PTH. So they end up wasting calcium and inappropriately retaining phosphate. And here's the tricky part. Because PTH is attempting to compensate, PTH is going to be increased. And since this is a problem with the kidneys, not the parathyroid gland, you're going to see that calcium and parathyroid hormone are inversely proportional. For the visual learners out there, this is going to be in the top left portion of the graph. Now for bonus points, which one of these is going to see elevated alkaline phosphatase as well? The answer to that would have to be the parathyroid adenoma, because of the acute increase in bone turnover. Finally, the last type of important high-yield question that you're going to see is a set of labs that you have to interpret, kind of like this. Now, what disease do you think this is going to look like? Pause the video if you need to. So, if you're trying to remember the graph in your head, you'll notice that I was a little bit tricky and didn't give you the parathyroid hormone value. But there is enough information to make a diagnosis. Though the calcium is low, the alk phos is high, telling you that there's bone resorption taking place. Now, usually this is due to increased parathyroid hormone. And when you see that decreased active vitamin D, you can be pretty confident about the diagnosis that you're dealing with secondary hyperparathyroidism due to chronic kidney disease. All right, gang, well done on these questions. These are some of the most challenging ones you're going to see on the endocrine section, but also some of the most important ones to practice. They're kind of like math. You only really get good at them after doing a bunch of them. But for now, we're going to move on to pathologies of the pituitary gland.